Hey, future respiratory therapist, I got another video here for you. I'm going to answer a question here that comes from Maria, who is not a future respiratory therapist. She is a current respiratory therapist. And she brings a very good point to light. And she talks about how specifically new grads come out and they're constantly adjusting FiO2 based off of PaO2 instead of SpO2 or SaO2. Now, the question is that how do I talk about the oxyhemoglobin dissociation curve, which is what I understand to be your main point in approaching this conversation with new grads, and how do you get them to understand it? Now, here's what I'm going to say to you, Maria. I don't typically talk about the oxyhemoglobin dissociation curve very often with my students because it is such a complex conversation that it typically doesn't really lead anywhere. I'm not saying it's not one worth having. I'm just saying it's so complex in getting people to understand the reduced affinity associated with acidosis states and the increased affinity associated with alkalotic states. And you draw this graph for them, and it just simply doesn't ever really resonate. And so I get what you're saying. So let me tell you how I try to drive home the concept of SaO2 being more valuable than PaO2. The first thing I do is point out that PaO2 is more of a reflection of efficiency of the lungs. So if you have a good PaO2 and a high PF ratio, then you have lungs that are effectively diffusing oxygen from the alveoli to the arterial circulation. That makes sense, right? Like the lungs are doing their job. Now, from there, the lungs have nothing to do with oxygenation. Once the lungs do their job in getting oxygen from within the alveoli to within the arterial circulation, the lungs have nothing to do with it. From that point on, it has to do with a whole bunch of other things. So what I typically try to do is to bring home this concept of total O2 capacity or total O2 content. This is the formula that I use to drive home these concepts of stop looking at your PaO2, look at your saturation level, and assess from there. Now we know that, and I know you know this, Maria, I'm not teaching you right now, I'm teaching everybody else. We know that when we talk about total O2 content, we're talking about this formula here. Hemoglobin times 1.34 times SaO2 plus PO2 times 0.003. And this is where I typically make the most grounds. Because what I make them understand is that if you have a patient with, I'm going to grab my phone here because I'm going to need my calculator. So let me get my calculator up here. If you have a patient with a hemoglobin of, let's just say 14 times 1.34 and your oxygen saturations are 90%, which is 0.90, plus you have a PaO2 of 60 times 0.003, what I try to get them to understand is this. When we're talking about oxygen delivery to the tissues, and that's what people fail to understand, guys. People, listen, future respiratory therapists, listen to this right here. The reason we breathe is to provide oxygen to the tissues. The reason we breathe is to provide oxygen to the tissues. Our goal in breathing is to bring in oxygen to the alveoli that will diffuse over into the arterial circulation, but also and more importantly, bind to hemoglobin, which is where most of our tissue oxygenation comes from. Now, we prove this with this formula right here. Here, I say 14 times 1.34 times 0.9 equals 16.88 plus, clear that, do 60 times 0.003 equals 0.18. When I do 0.18 plus 16.88, I see that my total O2 content is 17.06. Now, let me illustrate this for you in a different manner, okay? So that you understand why saturation is more important than titrating or increasing FiO2 or decreasing FiO2 based off of PaO2. All right? Look, when we change FiO2, all we really change is arterial oxygenation. And what you're going to see here is this. I'm going to erase this. So let's just say that our hemoglobin stays at 14. We stay at 1.34. And you have somebody on a mechanical ventilator who has a PaO2 of 60. Okay? And you go, oh, that's mild hypoxemia. I want to increase it. So you increase the FiO2 for that patient. Then what you find is that your sats go up. Let's say they go up to 98%. And let's say your PaO2 goes up to 85. So what we see here is, remember, we started at 17.06. This is where we started with the first example. This was with a PaO2 that was 60, okay, with a SAT of 90%. What we find is that we have 14 times 1.34 times 0.98 equals 18.38 plus 85 times 0.03 equals 0.25. So now we're looking at plus 18.38 gives us 18.6. Now, do you realize how you've dramatically improved the PaO2, but you have not dramatically improved the total O2 content to your patient? That's what I would drive home, is this formula right here. I would talk about this formula. I would go into it and say, let's talk about this. Let's take our PaO2 down to 35. Now this is a severe example, okay? Severe hypoxemia, right? So we know our sats are going to be somewhere around the ballpark of 70. So if we do this formula, we see 14 times 1.34 times 0.7 equals 13.13 plus 35 times 0.003 equals 0.10. So this equals 13.2. We started at 17.6, I believe. We can see here where we have a significant reduction in oxygen being delivered to our tissues. Now, why is the oxygen being significantly reduced to our tissues? Is it because of our PaO2? No. It's because of our binding to hemoglobin. It's because of our SaO2. You got to understand, guys, when it comes to oxygen delivery to the tissues, which is why we breathe. We breathe to bring in oxygen for delivery to our tissues. When this is adequate, we have no problems. Nobody questions anything. But when you have a diffusion defect, you start seeing a drop in your PaO2. And you want to panic when your PaO2 is 58, yet your SAT is 90%. You got to go back to this formula to understand that it's this formula that drives tissue oxygenation. And the biggest two factors in this are hemoglobin and our saturation. Of course, if we have severe hypoxemia, you're going to have a low saturation and you're going to have a low tissue delivery. Of course. What we miss most of the times is rooted in something more along these lines. Instead of having 14, let's go back to the scenario we started. Let's say you have a PaO2 of 100. So PaO2 equals 100. You have a SAT of 99%, but you have a patient with a bicarb of 8. So let's talk about this scenario. You have 8 times 1.34 times 0.99 equals 10.61. Plus, we do 100 times 0.003, we're going to get 0.3, equals a total capacity of 10.9. Now, if you remember from where we previously came from, this patient has a worse state of tissue oxygenation than our patient did with a hemoglobin of 14 and a SAT of 70%. They were at I don't remember the number, but it was somewhere around 12 or maybe 11. I don't remember the number. But they were not at this state of 10.9. Okay? So you got to understand that it's this formula. It's not the oxygen dissociation curve, which is important, which you need to understand, the affinity for oxygen and hemoglobin versus the decreased affinity versus the increased affinity. It's all very, very important. But this formula, Maria, gives tangible data to what your student respiratory therapist or your precepting respiratory therapist or your respiratory therapists who are coming to you making these changes. This formula is the one that will illustrate the minute differences when you change PO2 versus when you change SaO2, and specifically when you change hemoglobin. This is the formula that I use every single clinical day to explain to my students why their patient has an increased lactate even though their PaO2 is 115, but their hemoglobin is 8 or 7 or 6. This is the formula that I find more useful in addressing changing FiO2 to increase PaO2 when it doesn't change the entire picture based off of hemoglobin first and saturation second. I don't care if the saturations are 90. I don't care if if their PaO2 is 57 or their PaO2 is 68. I don't care because I understand that the total O2 content is still acceptable based off of this patient's carrying capacity. I think that's where I would take the conversation. I think this is a much more tangible formula and a much more tangible road to go down as opposed to the oxyhemoglobin dissociation curve. So I hope I helped you. I hope this makes sense. Now you asked me another question and I want to try to fix it. I want to try to address it. And this is, how do you encourage staff without giving out free breakfast, free pens, free lunch, free dinner? The answer is this. There's got to be an entire staff that buys into a cultural change. See, if you have a staff that is only responsive to pens and free breakfast and free lunch and free dinner, then you have a staff that is not part of a culture. You have a staff that is responsive to incentives. Responsiveness to incentives is a reflection of a staff that is not buying into an underlying culture. And that's where I think you need to take this conversation, is asking yourself and talking to your leadership and talking to your respiratory therapist and asking, what type of culture are we trying to buy here? What type of culture are we selling? What type of culture are we creating? If you create, or if you allow a negative culture to fester, they will be extremely responsive to free pens and free lunches. But if you create a culture of positivity that is more focused on outcomes and patient satisfaction and everybody uplifting everybody else and recognizing the good that everybody is doing instead of recognizing the occasional faults that people have, then you're going to have a staff that is not ultra responsive to free pens and free meals because they're already happy. When the culture is negative and the focus is on, you didn't change all my waters, you left this nebulizer running, you made this mistake, you made this mistake, you made this mistake, then what you get is a pitting of night shift versus day shift. And this is a insanely toxic, negative culture in the field of respiratory therapy. And the only thing that makes these people happy, this negative culture, is short-term positive reinforcement, which is, here's a pen. Oh, we're so happy today because we got a free pen. That doesn't change the care that's being given throughout the shift. It doesn't change the culture. It just makes everybody, those super negative people, happy for one day because they got something for free. But when you have that positive culture and that staff that is always high, which starts, you have to grow it. It's not something that is innately just there. You have to develop it with time. And you have to start small. You have to start with the small group of people who get what you're trying to create. And then that permeates throughout the oncoming people. If your orientators, the people who orientate new employees, buys into this positive culture, then it becomes much easier because they're orientating to this positive culture. And it's all culture based. Take a super positive group and give them free pens and they go, thank you very much. But this doesn't change what I'm doing because I'm already super happy and super high about the job that I'm doing as a respiratory therapist. For this negative culture, free pens, free lunch, free breakfast, free dinner, all of that stuff makes them super happy for a short term. Specifically, just that shift. Even more specifically, on the more micro level, specifically just during that lunch or just during that dinner. And then once that's over, they're immediately back down to their negative state of mind and their negative culture and back to not even, they don't even remember. 6 hours after you give them a free dinner, they don't even remember that you just got a free dinner. They just remember how shitty their job is and how shitty their department is and how they're going to get written up for this and this and this and this and this. That's not a positive culture. Positive cultures are built on a certain level of expectation and a certain level of respect between day shift and night shift, between respiratory therapists and respiratory therapists, between respiratory therapists and nurses and doctors, and back and forth. And those positive cultures, I know I haven't given you anything here that's tangible, but what I'm telling you is your goal is create this state of positive culture that keeps your staff at a state of highness where they're just happy because they're at this happy place to work, where they don't work out of fear of retaliation and they don't work out of a fear of being written up and they don't work out of a fear of what they didn't do, but instead they're working for the greater cause for the patients. And that culture is one that is probably less receptive to pens and lunches. They appreciate them when they come, but they don't need them. because the everyday sense of clocking in satisfies them. They love coming to work because they know the place they're working and the people they're working with are all on their team and they're all working together. So Maria, I look forward to your messages. I look forward to your comments because I know you're going to have some. I want to encourage everybody to respond to this message and let me know what you think. What gets you up? Maria wants to know, how do you promote and how do you incentivize a staff to be better than what you currently are? If you're here and you want to go to here, it's a mindset shift. But if you're here and you want to go to here, then there's got to be something different. Talk to me, guys. Let me know where you're working. Let me know what your facility does. Give me some feedback so that I can pass it on to Maria. She will see the comments. She will respond and she'll appreciate the feedback, and so will I. Hope this helps everybody, and I hope everybody is having a great day and loving their journey to being a respiratory therapist or already working as one. Best wishes, guys.